Hello, everyone. My name is Sabrina Shem, and I am the head nurse for the Hospitalist Medicine program. And I have here with me Amanda Stewart. She is the iPace mentor for the Hospitalist Medicine program. Today's presentation is an introduction to the iPace Hospitalist project about early serious illness conversations.
We're going to start off with a little bit of background. So as we know, people are living longer with multiple comorbidities and higher levels of frailty. In fact, by 2025, it's predicted that only 20% of Canadians will die with an illness that has a recognizable terminal phase. So these less predictable trajectories are making it increasingly difficult to recognize the need for a goals of care conversation prior to a patient's decline or a crisis in their health. But they're also making it increasingly difficult to share prognostic information, which we know is essential for informed decision-making. So this leads to conversations occurring late in the patient's illness and limiting its impact on patient care and outcomes. The early integration and partnership of palliative care with active treatment is highlighted beautifully with the bow tie model of palliative care. Palliative care is person and family-centered care available for people living with any life-limiting illness at any stage in their illness. It is complex pain and symptom management that focuses on improving quality of life, reducing suffering, and promoting understanding of illness. When palliative care is integrated early and alongside active treatment, it has been proven to not only help patients live with better quality of life, but also live longer.
When people hear goals of care, they often equate it to code status. But what we really want to do is to promote this all-encompassing definition. You will see that patients' underlying values and priorities is highlighted there, because when people think about the importance of medical decisions that are being made, we also want them to consider the reasons why they were made as equally important.
This slide is to highlight the different intentions between the ACP and goals of care record and the MOST form. So the MOST orders of scope of treatment are medical order sets that utilize standardized language and broadly or generally categorize the level of medical intervention chosen. As we know, every M3 isn't going to necessarily pursue the same types or level of interventions as another. It is through the goals of care conversations that the care team explores the range of treatments available to align care with the patient's wishes and values. Documenting these conversations on the ACP and goals of care record will enhance communication and understanding of the patient's medical decisions selected on the MOST, as well as the ongoing care planning taking place.
So in Cancer Project, we are the first program at VGH to adopt this standard of practice through this pilot project. And this project was particularly relevant for our population because a great majority of our patients have very advanced chronic disease and life-limiting illnesses. And it was identified as a high priority target for quality improvement. So the purpose of our project is to have goals of care conversations early, and as well to increase all staff's competence and confidence in engaging in serious illness conversations. So historically, goals of care conversations were perceived to be physician-only responsibility, but in this project, our goal is to have everyone participate in having goals of care conversations. So nurses, OTs, PTs, social works, everyone brings their own lens and build rapport and engage in conversations with patients. And it makes sense to take a multidisciplinary approach. And we are achieving this by having each discipline integrate a few questions from the Serious Illness Conversation Guide into their admission workflow and throughout the patient's hospitalization, and then to document them in a unified location so that the information is easily accessible and can be shared with the whole team. As iPace mentors, we are here to support and mentor all staff in engaging in these conversations to increase their competence and confidence. So here's a very long list of the many benefits of having conversations early. And when we are able to integrate these conversations early into our workflow and also early into a patient's stay with us, then that is when we are able to see some of these benefits. And although many of them are for patients and families, there are also many for us healthcare providers. When we integrate these into our day-to-day practice and we provide care that aligns best with the patient's priorities and values, then we can get more fulfillment, less distress, and less burnout.
So we're just going to run through an admission example to show you. So those that have seen iPace presentations before or done some of the iPace training will be familiar with the serious illness conversation guide that VCH uses to structure these types of conversations. You may find that you already ask similar questions on admission or when doing the MOST form, and likely explore some of these key topics on the left-hand side in your day-to-day work. Like Sabrina said, we have been working to engage all members of the interdisciplinary team to identify and participate with patients who are high risk for complications around goals of care, and that when this information is offered up to them due to their clinical expertise or personal rapport with patients and families, they know to also document it on the advanced care plan in a unified location. So hopefully you've all seen this form by now. It's the Advanced Care Plan and Goals of Care record, which lives right behind the MOST green sleeve in the chart. You'll see in the picture the tab we've attached based on your feedback from one of our first presentations. As well, attached to every hospitalist admission PPO in Emerge. For accessibility, we've managed to have the Advanced Care Plan and Goals of Care record as part of the admission package to really help facilitate these conversations for you as soon as Emerge. You'll see also in the middle there, the screening tools section has been added. We'll show you the screening tools next, but this is based on feedback from physicians as well as other disciplines who felt that doing the screening tool would be easier if they didn't have to write it out each time. So it's more of a fill-in as opposed to narrate. So we've got that there for you. We also wanted to say that this document is a legal form and should be accompanied with the MOST. We're working to integrate the practice standard that this form is the one-stop shop for advanced care planning and goals of care record information. Because of the multidisciplinary approach, you'll see the tab there does have some of the suggested questions for the physician group from the Serious Illness Conversation Guide, as well as the surprise question, which has been assigned to the doctors as well. So these are the screening tools. There's three. Number one is the clinical frailty scale. This was assigned to the allied health group. It's a really great indicator for a patient's overall wellness and function. Number two is the SPICT tool. It hasn't been assigned to a discipline because it doesn't always apply and is a little bit lengthy, although we do see many clinicians completing it when it applies. So if you're sort of sensing that a patient is going towards supportive or perhaps needs some palliative care involvement, this is a really great tool to sort of justify and inform that decision. And then there is the surprise question, which was assigned to the physicians and thankfully is nice and short to complete. So it's really about the perspective we take on the care that we're providing, and is it appropriate if we feel like we wouldn't be surprised based on where we consider the patient to be in their illness trajectory. And I think being assigned to the physician group is really meaningful because there are some disciplines who don't have the medical expertise to be able to answer that question. And as sort of the team leader, hearing that perspective from you is really meaningful. Lastly, we just want to really enforce that it's important to sign and date on the advanced care plan because all of the information is being tracked. It is a legal form. So as the rest of your charting, signing and dating is really important, but also because we want to be able to give credit where credit's due.
So these are some of the physician examples that really highlight how some of those conversations led to a co-status decision, but as well as shared the patient's priorities and values. For example, in the top left corner, in this example, along with the documented conversation, the physician also completed all 3 screening tools to support the fact that this patient was a very high risk and definitely needed to have more ongoing goals of care conversations as a priority. And then you will see that at the bottom right corner in this particular example, where the physician on admission in Emerge was able to identify the patient's substitute decision maker when the patient was alert and lucid, because shortly after, in a matter of the first 48 hours, the patient decompensated and was no longer able to speak for himself. So it was very helpful to have had that information gathered at the very early stages.
These are some examples of multidisciplinary charting on the advanced care plan. So this we've got many examples to use, which is fabulous, but these really highlight the fact that if we each come with our piece kind of the puzzle, we can come together on a unified document to paint the complete picture of goals of care for a specific patient. If we start at admission and contribute throughout the patient's stay, these conversations can really be our compass to guide the care that we are providing. We encourage you to pause here if you want to read some of these multidisciplinary entries. Particularly the bottom left is a particularly good example, having the first entry by a physician, and then you can see quite a bit later the follow-up from a CML. So really great at sort of seeing the transition through a patient stay, but all of these examples are great, and this is really sort of our pride and joy for this practice standard. As well, we really want to highlight that we have seen quite a strong impact from this work. Sabrina and I have given a couple examples through the documentation that you've seen, but also just a thank you note from a patient's husband. So one of the physicians received this after using this approach through her conversations with that patient's family member. And it reads, "Thank you so much for being so honest, caring, knowledgeable, and indeed understanding regarding my wife's dementia. You made me realize that this is the long goodbye. Not easy, not in a straight line. Thank you so much." So it really speaks to how her approach in the conversations that could have potentially been quite distressing was actually very therapeutic for him. And it does speak to that illness understanding and really big impact to her being able to sort of make him realize what is likely ahead and support him through maybe some of the decision making they were having to make during the patient's stay.
Like I mentioned earlier, as iPace mentors, we are here to support the staff and really help them become more comfortable and build confidence and competence in participating in these conversations. So if ever you are wanting some support and are wanting to approach the conversation with a family or a patient and are having difficulties, you can always feel free to call us or contact us, and we are happy to come in and support the conversation. We are also here to educate patients and families and staff about the palliative approach to care. And we work collaboratively along all team members to help navigate any barriers that there may be to having goals of care conversations, and to help address ways that we can integrate serious illness conversation guide questions into all of our admission workflows. But really, most importantly, we want to be able to promote patient-centered care through informed and collaborative decision-making. So we really want to emphasize that the advanced care planning and goals of care record, when utilized appropriately, really is a communication tool that enhances the understanding of the patient's wishes for all members of the care team. It can really help avoid the repetition of time-consuming conversations. When we think about changing of teams and of primary physicians all the time, having these conversations documented in one unified location really helps us gain a deeper understanding or insight into the conversations and all the hard work that the previous physician has put in having these conversations. And more often than not, it really helps us avoid having to start over, and instead we're able to move the discussion forward. Sometimes when we are having these deep conversations with patients and families, we often find triggers. And if we have those triggers documented, then for the next person going in, then we can certainly avoid those triggers. And lastly, it can really help us save time digging through different sections or history notes of the chart in search for previous documentation related to goals of care. We measure progress in different ways. So firstly, we do chart audits quite frequently. So on a weekly basis, we audit all the charts on all the units, and this really helps us track participation and also identify any gaps that there may be so that we can focus some of the support. We also receive ongoing data reporting from decision support in relation to some of our secondary outcomes, like patient complaints, and length of stay and readmission rates, which we are all hoping to decrease, and also referrals to community services. And again, we continuously collect subjective feedback. So just like the lovely quote that Amanda spoke to earlier, and any success stories. If you have any questions or comments, please feel free to contact us at the email addresses listed below. And you can always come and find us on the units as well, and we are happy to help you at any moment. Thank you for your time today.
Thank you.